So thank you for having me. I feel like I should come back in 10 years when I'm really distinguished. But anyway, we'll see how distinguished I am to date. So thank you again for having me here. What I'm going to talk to you about is mostly about some work I've done using magnetoencephalography when I was doing my postdoc at the University of Toronto and Sick Kids. And I just want to acknowledge a bunch of people that I work with, my postdoctoral supervisor, Tim Roberts, as well as Wendy Roberts, the developmental pediatrician extraordinaire, and a bunch of colleagues there, as well as my esteemed colleague, Dr. Rob Nicholson, here in London, working now in the area of ERP because we don't have an MEG system here in London. Toronto has 3. I don't think it's fair, but anyway, if anyone knows someone with $2 million to buy us an MEG system, that would be super. Also working with Mark Joannis from psychology, and my colleagues Lisa Archibald and Daniel Ansari and I have been collecting data from a large school board study, and some of those children were invited to participate in our ERP studies, as well as my doctoral students, Heather and Margot, who are in the trenches with me running the ERPs, as well as some other research assistants in the lab. The MEG work was supported by NAR, which is now part of Autism Speaks, as well as CAHR, and our current work is funded by the Scottish Rite Foundation. So before I begin, I wanted to give you a crash course in some of the terminology that us speech-language pathologists like to use, and this is not exclusive terminology to speech-language pathology, but I just wanted us to all be on the same page when I'm using the terms communication and language. So here's my introduction to speech-language pathologies. This is me saying my name is Janice. This is the syntactic structure, and this is the international phonetic alphabet of me saying my name is Janice. Anyway. So communication, what do I mean by communication? When we use the term communication, we actually could be meaning one of two things. In one respect, communication is used as an umbrella term just to talk about anything that has to do with the exchange of information between a sender and a receiver. Okay, that can be speech, it can be language, it can be voice, it can be hearing. All of the elements that go together, we talk about communication. And so when we talk about the umbrella term communication disorders, we're talking about disorders of speech, language, voice, hearing. So that's sort of the domain of practice of speech-language pathologists, obviously, and other professionals as well. We don't have the market cornered on communication. But that's one way in which we use the term communication. Another way you'll hear the term communication used is specifically as a synonym for pragmatics or social communication, specifically talking about beyond the actual core linguistic devices to how you use those core linguistic devices for the art of conversation and interaction with other people, okay? Language, what we mean by language is really the linguistic structure or component, and that includes a number of subdomains like phonology or the sound system, morphology, which is the grammatical markers, syntax, which is the sentence structure, and semantics, which is sort of meaning and vocabulary. We talk about language from an input or receptive perspective and from an output or expressive perspective. And when we talk about language, it's really about the symbol system. When we use the term language, it's not just about oral or spoken language. It can also be written language, like reading and writing. It can be graphic language, like, for example, a bliss symbol, or manual, signed language. Okay, language is just a symbol system for communication. Speech. When we use the term speech, we mean something different from language, or else, the term of our profession would be sort of redundant, speech hyphen language. Why do you have both of those? When we use the term speech, we're talking about articulation or enunciation, or the way in which you use your oral mechanism to create speech sounds, to create voice, to create fluency. Meaning when you're not fluent, you might be doing something like stuttering. So all the features of the way you move your mouth and other oral structures to produce sounds. So when we say spoken language, we're talking about how you're using speech to communicate a language, but that's different from when we use the term speech. And so what I'm interested in talking about is the relationship of language, so the linguistic structures or spoken language, to different disorders like autism. Okay, I have to come back here. So let's talk about developmental disorders of language and developmental disorders of communication, and what do we mean by those. One disorder that I am very interested in, have always been interested in, is what we call specific language impairment. It goes by other names. You may hear it called language-based learning disability when kids are school-aged. You may hear it called developmental language disorder. What this refers to is people who have a problem from the onset of development in their understanding or using of language. And that can be in all or some of those domains of morphology, syntax, semantics, and so on. In these people, they have a problem with language despite otherwise being normally developing. They don't have any core neurological impairments like cerebral palsy or epilepsy or brain tumor that might be associated with a language problem. They don't have any sensory problems like a hearing impairment that we would expect to impair your language development, or at least your spoken language development. They don't have global intellectual or cognitive impairments, so it's not because they're globally low functioning, it's just in the language domain. They don't have any psychiatric impairments like childhood psychosis, which might predict some language problems. So they are otherwise normally developing except in the domain of language, okay? When we talk about autism spectrum disorder, as we all know in this room, one of the core symptom clusters is a qualitative impairment in communication, okay? So what communication do we mean? Do we mean anything, voice, fluency, artic, language? Do we mean communication as in pragmatics? What do we mean when we talk about autism spectrum disorder? Well, let's talk about that. There is a communication or pragmatic impairment across the population. It's pretty much a core feature, right? Everybody who has ASD has some element of problems with pragmatics. That's really quite a hallmark. And so that's using language for social purposes, whether it's knowing how to be relevant to your listeners' needs, whether it's being able to repair when someone doesn't understand, all of those elements of how to have a good give and take in conversation. From a language perspective, functioning is very variable across the spectrum. There are some people who don't even basically acquire language at all. So they really don't acquire a symbol system, be it verbal or manual. Okay, so it's just about language, not having a symbol system. So when we talk about language functioning, here we're talking about those core linguistic features. There are many people on the spectrum who have impairments in their core development of language, okay? Like I said, some who don't even acquire it at all, and some who are just very, very delayed, okay? Typically, most often, these are people who are labeled as having autistic disorder or autism, you know, when we talk about the DSM-4 or PDD-NOS, many people who have that label have some degree of a core language impairment. Not all. You can get a diagnosis of autistic disorder with superb language, because technically when you apply the DSM-4, you're supposed to first go to autistic disorder, see if you get enough symptoms. Even in the communication domain, a number of those symptoms are more pragmatically based. Some of them are more core language based, like fails to develop language, but you don't have to get that one, right? So, but having said that, many people who have enough symptoms to be called autistic disorder or autism do have language problems. There are other people on the spectrum who don't have any clinically significant early language delays. They may have pragmatic problems, but they don't have any early language problems. And so that's a core definition of Asperger's syndrome, that you have your onset of first words by 2, that you're speaking communicative phrases by 3. Now, it doesn't say people with Asperger's syndrome don't all have superb language skills, so you can have normal early onset, you can go on to have more protracted development and still meet criteria for Asperger's syndrome, okay? But most often, many people with Asperger's syndrome do have adequate linguistic skills. They may have communication impairment, but not language, okay? So, historically, when we've talked about language impairments, so core linguistic impairments in ASD, it's always been assumed, well, that's different from people who have core developmental impairments in language. The reason why their language is impaired is because of the features of autism prevents them from developing language normally, rather than there being something wrong with their linguistic learning mechanism per se. Okay, so their brain is okay for learning language, it just doesn't get the right input because of the autism behaviors. Okay, so we've just assumed that it was different. But a new idea is that maybe the language impairments in some people with ASD are identical to or very similar to those in people who have a core developmental language impairment like SLI. And so what's some of the evidence that we've been amassing for this? Well, there's some genetic evidence, so that whether you take a sample of people who have ASD and you look at what runs in their family, they're much more likely to they have more people in their family with SLI than other people in the general population. If you take a sample of people with SLI and you look at what's the occurrence of ASD in their broader family, it's higher than the general population. So these disorders tend to co-occur at a greater than chance rate. Okay, so there's something genetically linked about these disorders. From a brain perspective, we know that we typically have an asymmetry in our brains for language, in that your left brain in most people is larger in language relevant regions than in the right. You have atypical patterns of this symmetry, so atypical asymmetries. In people with ASD, so DeFosse's done a study where they looked at people with ASD who had a language impairment versus did not have a language impairment and compared them to people with SLI or DLD. And what they found was atypical asymmetries in language relevant regions, okay, and that were the same in the people with ASD who had a language impairment and SLI. The people who had ASD without a language impairment looked like controls, so had the typical asymmetry, okay? Martha Herbert has done a number of studies comparing kids with autism who had language impairments with SLI and found identical patterns of this sort of overgrowth of white matter areas relevant to language. Okay, so there seems to be some similar neural structural patterns in both of these disorders when there is a language problem involved. Okay, so there's some more evidence. From a behavioral perspective, you can see similar profiles on language measures. So on standardized language measures, you can see the typical SLI profile in some kids with ASD. When you go deeper and you look at what we call our markers of SLI, so these core processing tasks like non-word repetition, so phonological processing tasks, or specific grammatical marker tasks, you can see a subgroup of kids with ASD who have these same core SLI impairments. One of the missing links, though, is we've got these interesting similarities from genetic and neural perspective. We've got these interesting behavioral language profile, but that's a big jump to suggest or to try to think about what happens between something being wrong with the genes in the brain to make language go wonky, right? So there's still a big missing connection there. How does an abnormality in the genes or the brain lead to language developing atypically, okay? So what's one candidate? I'm really interested in looking at some of these underlying, more core, basic markers that are more independent from the big complex thing that is language. And so one of the interesting candidates relates to auditory and speech processing. So no one's really done much research looking at combined groups where kids have autism and SLI and you compare them. But in the autism literature, there's a bunch of studies looking at basic auditory and speech processing showing abnormalities. And then there's another body of literature in the SLI world that identifies auditory and speech processing abnormalities in SLI. And so then the thought is, you know, what happens if we compare those? Is there something similar? Is this a potential candidate? Can there be something abnormal about the way the brain processes sounds at a very basic level that provides a sort of shaky foundation upon which you can build your phonological system and your language system. So if you're not hearing the speech stream or processing it exactly correctly, does that mess you up for getting those grammar markers and developing your vocabulary and so on? So that's what I became interested in. One of the problems, though, that I'm familiar with from having spent 9 years in the trenches as a speech language pathologist at Sick Kids, and then when I subsequently went to look at processing in my doctoral work using behavioral tasks, is that just because someone performs poorly on your standardized test or on your computerized processing task doesn't mean they have a problem in the thing that your test is designed to test. right? And so that was sort of the frustration that I developed, that we rely on kids learning how to do the thing you're asking them to do, attending to the stimuli you're presenting them, remembering that, you know, I want you to press this button if you hear this, and this button if you hear this. And so if you have problems in learning, memory, attention, you can perform poorly on a task that maybe you actually have the core abilities to do, okay? And that was what grew out of my doctoral work. I was actually comparing kids with SLI to kids with ADHD using computerized processing tasks of auditory perception. And the kids with ADHD who had no language problems whatsoever bombed the language processing measure because attention, memory, learning. So that's when I got a postdoc to work with a bunch of imaging physicists for 2 years, which was an interesting 2 years of my life. You don't typically have speech-language pathologists hanging out with imaging physicists, but it was actually very productive. And so one of the potential solutions to looking at, you know, getting underneath the behavior is to let the brain tell you the story, right? What if you don't, all you have to do is sit still and your brain tells us how it's processing things. And that's what EEG and MEG can allow us to do. So when we measure your brain waves, we're able to get very precise information on the timing of how your neurons are processing. EEG and MEG have millisecond resolution, so it can measure at the level of millisecond changes, and that's how quickly things happen in your brain, okay? That ends up being very valuable for evaluating the underpinnings of speech processing, because when we process the speech stream, there are very rapid millisecond by millisecond acoustic transitions. For example, the difference between ba and pa, they are acoustically quite similar except for an initial formant transition, so that's a change in the frequency sweep in the first 40 milliseconds. So if you had a problem in processing at that resolution, then you might miss some of the critical information to help you discriminate the sounds, okay? So that's why EEG and MEG are valuable. Now, you can do reaction time studies that help you at millisecond levels as well. But one of the nice things about EEG and MEG is that you can design paradigms where the kids don't have to do anything. You present stuff to their ears, and as long as they're sitting reasonably still, you will get some millisecond by millisecond information from their brains. So now this is time for crash course number 2 for those of you who may not be familiar with EEG and MEG, okay? And then we'll launch into talking about what I've been doing with my colleagues. So basically, they are all founded on the basic physics principle that when you have electrical activity, like you do in this telephone wire here, the electrical current passes in a linear direction along whatever the wire is. And when you have an electrical signal, any electrical signal has a magnetic field surrounding it, okay? So that's happening in this telephone, and the exact same thing happens in your neurons. So EEG measures that electrical activity, so wherever your neuron is shooting or directed, that electrical activity comes out your skull, and while it's coming out your skull, there's a magnetic field around it that would come out this way, right? So you can imagine it comes out this way, and the field goes in and out of your head this way. Okay? So that's what these technologies allow us to measure. So this is non-invasive, so there's no radiation, so we're not electrifying or magnetizing the kids' brains. We're measuring what we're all sitting here with electrical and magnetic fields coming out of our skulls. Obviously, they're very small, but we can measure those, okay? They do come through the skull to some degree. So here's an EEG system. This is a different kind of system, but it's the basic principle that you have a sensor attached to the skull, and it measures the electrical signal. And this is a magnetometer, and it has a dewar with all of these individual sensors. Each one of these sensors represents the same thing as these little dots stuck on the head. In this case, you put the cap or the net on the head. In this case, you stick your head into the helmet. Okay? But they're measuring the same thing. Now, you can actually also put an EEG cap and stick yourself into an MEG and get simultaneous information. And that's what they did do at Sick Kids. This is actually the system that they use for pre-surgical mapping for epilepsy. And so they get complementary information for both. So those kids go in with both EEG and MEG. I didn't want to get into that because it's hard enough getting them into the system in the first place. So here's the facilities that we use. This is at SickKids. This is a 151 channel biomagnetometer. This is the one we use for our work. They now got a second one, so they have a 256 research dedicated one, and this one's reserved for clinical. Also unfair that they get two. So this all is housed in a magnetically shielded room, so it has to be designed sort of like an MRI suite. It's on a big concrete pad. It's got a big fancy booth. This big canister at the top is a canister of helium that has to be changed twice a week to keep the doer cool, keep the sensors cool. So it's a little bit, you know, it's a lot more expensive and a little bit fancier, and you have to have electrical engineer or not mechanical engineers who come in and maintain it and all. It's very fancy. But that's me in my younger days with some about to go into the system. And then the EEG facilities that we use here in London are housed at Western in the National Centre for Audiology, where I'm an affiliate member. And we have a soundproof and electrically shielded booth right in Elborn College building where we live. And we are using a 128-channel geodesic EEG system. And so this is a geodesic net that's on this lovely child. And there she is all plugged in with her insert earphones and her movie ready to go. So how do we measure? What we do is we measure the neural response to sound in our work, and here's an example of an EEG averaged waveform. So each of the lines in this tracing represents one of those sensor spots on the head. And so you get the presentation of the sound, and this is actually an adult response, about 50 milliseconds after it's presented to the external ear canal, you get a response that's called the M50 that comes out here and is thought to represent activation in the primary auditory cortex. And then about 100 milliseconds later, you get the M100 around the same region. Okay, and these are the things that we measure. And this is sort of time, so about 50 milliseconds, about 100 milliseconds. EEG is similar, but you get a different kind of tracing. Again, you have the sound is presented, and then this is a child's waveform. And so somewhere around, depending on the age, 80 to 100 milliseconds after the response, you get a positive electrical burst that we call the P1. And then somewhere around 250 milliseconds after the onset of the tone, you get the N2. In adults, you typically see a P1, N1, P2, and then sometimes an N2 in response to a tone. In kids, you see more of a P1, N2. So just for those of you who are familiar with ERP, that's why you don't see the N1 here, because this is a kid. So then what do we do? What we do is we record an ongoing stream of electrical or magnetic activity. We present a stimulus many, many times. So at least 100 trials in MEG, at least 200 trials in EEG, because we have to throw out anything during which time they blinked. And so obviously you can't stop people from blinking, so you lose a chunk of trials to that. So you get it to the same stimulus, and then you average all of those trials together. Because there's ongoing electrical magnetic activity to everything, because you're thinking, you're breathing, you're blinking, you're moving a little bit. So there's lots of electrical activity. But when you average them together, anything that is random noise averages out, and the only thing that's left over is the response to the stimulus that you presented. And so those waveforms I showed you are characteristic auditory responses. Okay? Then we identify the characteristic peaks like the M50, M100, P1, N2. You can identify them by peak picking as an expert reader. We're also experimenting with ways of automatically identifying windows for peaks using principal component analysis. I won't present those here yet because we haven't got that all sorted out. And then once you have your characteristic responses, you measure the amplitude of the peak, meaning how strong was it. In MEG, it's what is the femtotesla, what's the magnetic strength, and in ERP it's microvolts, right? So what's the voltage of that response? How big was it? And then in some cases, particularly in MEG, EEG is a little bit trickier to do this, you measure the timing or the latency of the peak. So how many milliseconds after you presented it to the external auditory canal did it occur? And then you have a measure of timing. So our general approach in our work has been to study school-age children And we have kids who don't have any known neurological problems, like I mentioned, like epilepsy or CP, or any hearing impairments. Then we typically use some sort of a Wechsler measure to get their nonverbal IQ, and we only take kids who are scoring at least a standard score of 85, because that's a definition of SLI. If we had kids with ASD who had variable IQs, then they're not necessarily sort of comparing apples to apples. In MEG, you can't have any kids who have any sort of fixed metal. We discovered that 15-year-olds wearing heavy eye makeup also don't work because there's lots of iron in there. We lost that one. Any kids with autism who have those metal caps on their teeth, we couldn't assess because that causes an artifact in MEG, less of a problem for EEG. And then the key, I have a star beside it, is the one thing we do need is that you're functional enough that you can participate in a standardized test like the WISC or the SELF. So obviously there's a segment of the ASD population that are not able to do that. And then they have to be able to lie still in the MEG system or sit still in the ERP system, relatively still enough for a 5-minute period. In EEG, we're only doing 5-minute blocks. In MEG, some of our blocks went up to 12 minutes. So obviously some kids might be able to do standardized testing, but they can't necessarily sit still, or they turn out to be a repeated jaw clencher or something, which causes too much artifact. And then what we've been doing is sort of the 4-group double dissociation design, where we have kids crossed according to whether they meet criteria for ASD and whether they meet criteria for language impairment. So the kids with ASD, we've been using sort of ADOS ADI. That's what we use for all 4 of our groups, in all 4 of these groups in Toronto. Here we're using it just for the ASD groups, just for a resource reason. In London, we make sure that kids with SLI and typical development don't meet criteria for ASD on the SCQ, so as long as they aren't above the cutoff. And then from a language perspective, we give everyone the SELF-4, and we look for a standard score 85 or above for normal language and below 85 for language impairment. And so you'll see we have a group of kids who I call ALI. This is ASD with a language impairment. And then we have a second group of kids, ASD language normal with no language impairment. And then we have the SLIs and the kids with typical development. So here's the first study that I'll talk to you about. This was a study where we were really interested in looking at one of these potential markers. So this MEG study we did was looking at rapid temporal processing, looking at how well kids are able to process rapid transitions in auditory stimuli. Back to this theory or idea that there may be a fundamental problem in processing quick changes in sensory input. Paula Talal from years ago was an original proponent of this theory. Some of this work has gone on and expanded. So we were looking at whether this was a core problem, and the theory being that if you have problem processing rapid acoustic transitions, you're going to miss some of the important acoustic transitions you need for understanding and perceiving speech, upon which you will build your linguistic skills. So we studied 40 kids from a fairly wide age range, children and adolescents, and we divided them into those 4 groups. In this early work, we were calling the ALI group autism and their ALN group Asperger, but they weren't really autism and Asperger because they weren't, technically defined that way by the DSM-4, but it was more by whether they were impaired or not on the self. So in our subsequent work, we've been calling it ALI versus ALN. And the task that we used was the 2-tone task. And so let's see if this works. If I stand close enough. Okay, we're putzing around with the screen so much, I never tested that. Anyway, I'll give a live demo. Beep, beep. So basically they'd hear beep, 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 beep. And what we're interested in is at that 150 millisecond gap, was that too fast for the child's brain to show us a response to the second tone? Okay? And so they sat still, watched a movie. At that time we were running Pengu. We now have a better selection of movies to watch without sound. But for those of you who may or may not know Pengu, he's a clay penguin on TVO, and it's claymation, and there's no sound. He just says wah, wah, but there's no communication, so you can understand the story without sound, because of course they were listening to beep beep. And so what we're looking for is evidence that their brain processed the second sound. And here's evidence. This is the M50 and the M100. You see here, this is the red and blue represent in and outgoing. Imagine a circle coming in and out of the head. It's happening over, this is the nose and the ears, so this is left primary auditory cortex region, sort of left temporal lobe. And then you see the M100 to the first tone, and you see the exact same pattern, somewhat smaller, but it is there, to the second tone. So we're looking for, did you show this evidence to the second tone, indicating that you showed rapid temporal processing at 150 milliseconds. And so what we did is we looked at what are the proportion of the participants in the different groups who showed the response to the first tone and the second tone. So the vast majority of the participants, we had identifiable responses to the first tone. But it was different when we looked at responses to the second tone. The majority of kids with autism who had no language problems and controls also showed responses to the second tone, but a significantly smaller proportion of kids who had a language impairment, either in the context of autism or in the context of SLI, they were much less likely to show a response to the second tone, showing us some evidence of some problems in rapid temporal processing in a subgroup of these kids. So this was a nice way of showing this deficit without the participants having to actively participate, okay, other than staying still and letting us put them in the system in the first place. It appeared that this rapid temporal processing deficit was associated with language impairment rather than ASD per se, because we had a much smaller proportion of kids who had language impairments who were showing this second tone response. Does that mean that rapid temporal processing dysfunctions cause language impairment? This study does not answer that. It's not causal, but it's a little piece of evidence along the path. It's nice to show that these passive tasks complement the literature using more active tasks where kids have to press buttons and remember things. A second study we did is we wanted to look specifically at speech processing, and so we were using looking at their ability to detect changes in vowels using a magnetic mismatch field experiment. In ERP, these are called mismatch negativity experiments, so MMNs, and it's basically a classic standard deviant paradigm where you hear, most of the time you hear one stimulus like and every once in a while, randomly, 15% of the time you'll hear ooh, ooh, ooh. And so we ran this with ooh as the deviant and ah as the standard, and then we ran it as ah as the standard, ah as the deviant, ooh as the standard. We also ran it with tones that were 300 and 700 hertz, which is the carrier frequency of an ooh and an ah. And so we just ran a whole bunch of those. These are the longer ones. These are the ones that take 12 minutes to run. And what we're looking for is the MMF response. So what you do is you take all of the ooh neural responses and you average them together, and so this is the response to the deviant. And then you take all the ah responses and average them together, and so this is a response to the standard, and then you subtract them. And the reason why is because in both the deviant and the standard, you're going to get this initial response, the M100. This is a kid, and so that's why the M100 is actually happening at about 150. That's kind of like, oh, I heard a sound, right? That's what the brain is kind of saying. Oh, there's a sound. They're not saying what it is. But then, in the case of the ooh, they're like, oh, I heard a sound. Oh, it was different from the sound I just heard. And so that's the deviant response. And so when you subtract the, ah, I heard a sound, you get just sort of an emphasis on, oh, it was different, right? And so that's thought to be a representation of the beginning of sound discrimination, right? That this is distinct from, I've analyzed it enough to know it's not, that it's a different sound, and putting you on the path to identifying, oh, it was an ooh. So what we studied, this was a smaller group of kids because we had to run this 4 12-minute runs. So that's a subgroup of kids who can tolerate that before saying, I'm out of here. So we had 9 kids with typical development and 7 kids with autism who had a language impairment. And we were able to identify a mismatch response in all children for at least one of the stimuli. So that was suggesting that the kids with autism are not having problems recognizing change, okay? Because they were just as likely as the controls to show, oh, I heard something different. But the timing of that mismatch response was delayed. And so here's the vowel responses. This is in milliseconds. So the kids with typical development showed the mismatch response at a faster latency in milliseconds. The kids with autism showed it. It just was like, oh, I heard a sound. Oh, it was different, right? So there's like this little delay in their brain saying that they heard it. We did a later analysis once I was actually on maternity leave when they did this. We finally got enough kids with Asperger's syndrome, so we analyzed them to compare to the kids with autism who had a language impairment. These were, Asperger as in autism spectrum without a language impairment. And interestingly enough, that group showed even faster mismatch response than the controls. So it was like, there was a sound, oh, it was different, right? Really fast. And so what this means, we're not really sure. It wasn't a very big sample, but that's something that we found interesting. So again, in this study, we were able to show passively some evidence for delays and impairments in speech processing without the children having to respond. We didn't have enough kids with SLI in Toronto to be able to run this, but that would be a really interesting question, right? The next step is, do the kids with autism who have a language impairment look like the kids with SLI? And then this accelerated speech sound discrimination in Asperger's syndrome needs to be replicated because it was sort of just a poster we presented. We didn't even publish it because it was sort of, a small sample. But, is this a genuine finding? Does it relate to something like auditory hypersensitivity? Something worth pursuing further. Another paper I wanted to discuss, because this one was sort of really interesting and exciting to me, was looking at doing away with the four-group design. Because I always feel so uncomfortable. Well, what if I picked 80 instead? What if I picked 78 as my cutoff, right? Is a kid who has an 84 really on the self really different from a kid who has an 86 on the self? You have a language impairment, but you don't, right? So really, what happens if we just do away with diagnoses and we look at what are your performance levels, what's your IQ like, what's your language like, what's your autism behavior like, and are any of those things related to what your brain does? And so what we did is, on all the kids we ran in MEG, we always started off with a 300 millisecond, so a nice long 1 kilohertz tone, just beep. And we'd just run that 100 trials. We'd average it out. We'd look at it to make sure that there wasn't some weird metal artifact, that we were getting something before we actually put the child through the pain of doing, all of our experimental paradigm. So we had this on a lot of kids, including ones who ended up not meeting our criteria because their nonverbal IQ was too low, or they ended up, that was the only thing they tolerated. So we had this on 45 kids. Some of them had, an autism diagnosis, some of them had SLI, some of them ended up coming in as SLIs, but their language wasn't all that bad. So it was just any kids with any ability level who we were able to get this stimulus run on. And so what we did is I looked at the M50 and the M100 in both the left hemisphere and the right hemisphere, because we had run this binaurally. So we'd presented it to both ears, so we'd presented it to both sides of the brain. And we did, first of all, a developmental regression analysis where we took the latency of those responses, right, in milliseconds. What time did we see the M50 and the M100 in each side of the brain? And we looked at how well does that predict your nonverbal IQ. And then we ran another analysis, how well does that predict your language? How well does it predict your autism behaviors, okay? So going the other direction, starting from the brain and seeing what it tells us about your behavior. And then we did a logistic regression analysis and ROC curve analysis where we were looking at how well does it predict your status as a person with or without a language impairment. So predicting development, what we found was these evoked responses to the simple beep were not predictive were not predicting your nonverbal IQ, so they weren't related to nonverbal IQ in any way, and they weren't predicting your degree of or presence of autism symptoms on this was on the ADOS, their RAW score, which was, not the greatest use of an ADOS. The RAW scores are a little bit, there's a challenge with doing that, but, it was what it was. But the latency, the timing of the M50 in the right hemisphere, right, your non-language dominant hemisphere, was significantly predictive of your oral language ability. The slower it was, the lower your language skills were. And there was, to a lesser extent, the timing of the M100. That accounted for 36% of the variance in your oral language ability, which is pretty good for this teeny little beep, right? So then we moved on to predicting whether you had a clinical diagnosis. And so what we did for that is we said we knew whether the kids had a history of early language delay, because we'd done the ADI on everyone in this study, and that's one of the questions. So we knew if they had a history of early language delay, we knew their current language functioning. So if their core language score and their early history was impaired, then we said you have a language impairment, and otherwise we said you did not. So 19 of the 45 kids had a language impairment. And then we looked at this right hemisphere M50 timing, and it had a 71% overall predictive accuracy. It had 88% specificity and 50% sensitivity. So based on what was the millisecond timing, it would predict your language impairment diagnosis. Not fantastically, probably not any worse than some of the measures that Louise was reviewing last, like the MCHAT and so on. So then I got to thinking, though, what if we look more specifically at your receptive language? Because if you have this problem processing auditory speech stimuli, wouldn't you expect that that would mess up your receptive language? We have some kids who only are impaired in expressive language. Would you really predict that processing problems would only lead to problems expressively? So I reanalyzed according to the kids who had a low receptive language index on the self. So they had not just a language impairment, but they were impaired in receptive language. So there's 13 of the 45 kids. And then the predictive accuracy got even better. So 82%, 92% specificity, and 70% sensitivity. Again, pretty darn good for a little beep, right? Which the kids didn't have to participate in. So clearly the auditory evoked fields are predicting something about your oral language ability. It's not some generic indicator of a globally, delayed brain. If that were the case, then you would also see it predicting your nonverbal IQ. But it really seemed to be related to this construct of language. And it really seemed to be tied to impaired language comprehension as opposed to language expression. So it could be that this is really honing in on something that's abnormal about the right temporal lobe, or it's something to do with the left is not working well, and so it's the timing of things in the right that's sort of compensating. And the right side of your brain is not necessarily designed to be dealing with rapid transitions. It's really your left brain that's more interested in that, and so that's why it tends to specialize in language, or at least in oral language. So there might be something there. Obviously, this is, it had some ability to predict language impairment. It's not good on its own, but if you imagine being able to identify a few other markers that also have some decent predictive abilities, and if you combine them together, maybe you could get quite good. So it could be that this has some, promise for the future. So we'll leave that there for now. And we'll move on to what we're doing now here in London. So this project is ongoing. So I don't have a lot of data to present because we're up and running right now. What we're interested in looking at is similar questions. We're going back to that rapid temporal processing, the beep beep stuff, and really trying to hone in on what is the timing that kids with language disorders need in order to be able to show responses to a second tone. So another way of describing that is their auditory window of integration. So the way our brains work for processing our sound world is that we integrate acoustic information when it's in close proximity to make a single sort of acoustic or auditory percept. That's really efficient, right? Because we can't just go by processing everything in isolation. We have to integrate. But if you have a fairly big window, meaning that you need a fairly big gap, there's lots of stuff that happens close together that you're integrating together, and you're losing some of the sort of fine acoustic detail. If your window is big enough, you might be missing stuff that's important for discriminating the sounds of your language, okay? And so I'm interested in finding what is the auditory window of integration in kids with language disorders versus those without. We know that your window of integration becomes smaller with development, okay? So this is a refinement of your acoustic and auditory processing system, so it is important. So the sample that we're going for is one in which we have two groups of kids, 6 to 8-year-olds and 9 to 11-year-olds, and we want to stratify these two age groups across 4 other groups. So you end up sort of with 8 groups. You end up with kids with ALI, ALN, SLI, typical development in 2 age bands. Again, the same stuff, no sensory or neurological impairments. We're using the Wechsler abbreviated scale of intelligence to estimate their performance IQ, only taking kids who are 85 and up on that, using the self to delineate language impairment. The kids with ALI and ALN are defined based on a DSM-4 ADOS ADI diagnosis, and we're using the SCQ to say that the kids with SLI and typical development don't have autism. And the paradigm that we're using is similar to the beep beep task, but we're using multiple conditions of this. And so they hear 2 tones, they're fairly short, they're only 50 milliseconds, and they have, at first we run it just a single tone, the 1-tone condition, and then we run it in 4 different conditions with different sizes of gaps, 100, 200, 300, and 400 milliseconds, right? So one of them is beep beep, and one of them is beep beep, and then the next one is beep beep. Okay, so it keeps getting longer. So, and trying to find in individual kids what's their auditory window of integration. And so here we have an example. So what we have now, we just presented this month at the Symposium for Research in Child Language Disorders, is that we had enough controls and enough kids with SLI to do a comparison of those two. To date, we have 3 kids with autism with language impairment and 4 kids with autism without language impairment who we've run through the whole paradigm. So what we found in comparing kids with SLI to controls, here's a kid with typical development on a single tone. So there's the P1, N2 with the little arrows. Here's with the 2-tone 400, P1, N2 to the first tone, P1, N2 to the second tone. There they are to the 300, there they are to the 200, they are not there to the 100, okay? Here's a kid with SLI who really doesn't start showing a P1, N2 to the second tone until a gap is 400 milliseconds, okay? So we did that, analyzed that in the 10 kids with SLI and the 25 kids with typical development. And what we found was that most kids with SLI and typical development were showing evoked responses to the second tone at 300 and 400. Not all of them, but most of them. Most of the controls were also showing an evoked response to the second tone at 200 milliseconds, but most of the SLIs were not. And so we see this shift or delay in where that auditory window of integration is. We might say that the auditory window of integration for kids with typical development of this age band is greater than 100 milliseconds, but less than 200. It's somewhere in between there. With the kids with SLI right now, it's looking like it's greater than 200, but less than 300 for most of the kids. So hopefully, what I can't wait is to get bars in the ASD section here. So hopefully, you can send us some kids. Why am I doing all this, right? Why am I interested in all this? The idea is to try to identify these markers, right? These biomarkers of abnormal speech and sound processing in the brains of people with ASD and SLI using these technologies. The long-term plan for this is that we're doing this now in people for whom we know you have a language impairment or we know you have ASD because you're old enough. We can use tools that we rely on quite well. So in these kids, we don't really need to find the brain marker because we already know. It's pretty obvious to us. But the point is, if that brain marker is robust, then can you bring it down into much younger children? Can you get down as far as kids who are late to talk, right? That is the challenge for speech-language pathologists. Are you late to talk because you're a late bloomer and you're going to go on to be fine? Or are you late to talk because it is the first sign that you have something else going on and this is going to be a persistent problem? And we have some behavioral techniques for trying to sort that out, but it's not 100%. So can we use these tools to say, oh, here's another risk factor you have. Your brain is showing us a typical characteristic of kids who go on to have a problem. Can we get even better and do it in babies before we wait to see if you're late to talk? Do you have that brain marker? Are you at risk? Can we do it in fetuses, right? We can't do it with ERP, but there is a fetal MEG where you stick your belly in it and you can get auditory evoked responses in a 3rd trimester baby. Right? So wouldn't that be cool? Woo! We'd have to get a fetal MEG in addition to the MEG system for the brain that I want us to buy. So we're still looking for our sugar daddy on that one. So that would help us with a lot of the stuff that as speech-language pathologists and as developmentalists in general, we're all about, right? Can we prevent it? Can we early detect and sort of change your trajectory? Can we intervene early and help you? This also could be an objective independent marker of your efficacy of treatment. If it's related to the progress of your language, can we use change in these markers as indication of progress according to treatment and give us an index of whether we're on the right track with our treatment? Then, from an intervention perspective, back to the discussion we were having about learning and change, can we find a way of altering the input such that we make your neural biomarker look more normal? Because if we can do that, then can we do treatment that's directed at changing that input? And so, you know, fortunately for me, we have the National Center for Audiology, where we are leaders internationally in digital signal processing, so using different kinds of hearing aids. So digital signal processors don't just amplify, they can modify temporal information and spectral information in the incoming signal. So could you design a hearing aid that modifies the acoustic input in a way that allows your brain to become more normalized to respond to these rapid transitions? So, I mean, these are all potential applications of this kind of work. And that's it. Thank you very much.